Bismillahirrahmanirrahim. Childhood tuberculosis. Diagnosis of TB in children. There are some general considerations which include the following. The diagnosis of TB in children relies on careful assessment of all evidence derived from a careful history, clinical examination, and relevant investigations such as tuberculin skin testing, a chest X-ray, and sputum smear microscopy. Most children with tuberculosis will have a pulmonary TB. Although bacteriological confirmation of TB is not always feasible, it should be tried whenever possible, as for example by sputum microscopy for children with suspected pulmonary TB who are old enough to produce a sputum sample. A trial of treatment with antituberculous medication is not recommended as a method to diagnose TB in children. The decision to treat a child should be carefully considered at once, such as decision is made such a decision is made and the child should be treated with a full course of therapy. The key risk factors for childhood tuberculosis are household contact with a newly diagnosed smear positive case, and if the age is less than 5 years, and if there is severe malnutrition or immune suppression. Recommended approach to diagnose tuberculosis in children include the following. Careful history, including history of TB contact and symptoms consistent with TB. Second, clinical examination, including growth assessment, doing investigations such as tuberculin skin testing with bacteriological confirmation whenever possible, investigations relevant for suspected pulmonary TB and suspected extrapulmonary tuberculosis. First, the careful history including history of TB contact and symptoms consistent with TB. The close contact is defined as living in the same household as or in frequent contact with a source case with sputum smear positive pulmonary TB. Source cases that are sputum smear negative but culture positive are also infectious, but to a much less degree. The symptoms, the commonest symptoms are chronic cough, an unremitting cough that is not improving, that's to say, not responding to non-specific measures, including antibiotics, of no anti-TB effects, and has been present for more than 21 days. Fever, body temperature of more than 38 centigrade for 14 days after common causes such as malaria or pneumonia have been excluded. Documented weight loss or failure to thrive, in addition to documenting weight loss, or failure to thrive through nutritional plan for 4 weeks it is necessary to look at the child's growth chart. The clinical examination, including growth assessment, there are no specific features on clinical examination that can confirm the presenting illness is due to pulmonary TB. Some signs, although uncommon, are highly suggestive of extrapulmonary TB, such as TB organs other than the lungs. Other signs are common and should prompt an investigation into the possibility of childhood TB. Important physical signs include the following: physical signs highly suggestive of extrapulmonary TB, such as Kippos, especially of recent onset resulting from vertebral tuberculosis, and non-painful enlarged cervical lymphadenopathy with fistula formation. B. Physical signs requiring investigation to exclude extrapulmonary TB, such as meningitis with subacute onset or raised intracranial pressure and involvement of cranial nerves. Pleural effusion, pericardial effusion, distending, distended abdomen with ascites, non-painful enlarged lymph nodes without fistula formation, non-painful enlarged joint, signs of tuberculin hypersensitivity, as for example, follicular conjunctivitis, erythema nodosa, the documented weight loss or failure to gain weight, especially after being treated in a nutritional rehabilitation program, is a good indicator of chronic disease in children of which TB may be the cause. The investigations include the following: tuberculin skin test. A positive tuberculin skin test occurs when a person is infected with Mycobacterium tuberculosis but does not necessarily indicate disease. However, the tuberculin skin test can also be used as an adjunct in diagnosing TB in children with signs and symptoms of TB and when used in conjunction with other diagnostic tests. There are a number of tuberculin skin tests available, but the TST using the Mantoux method is the recommended test. Sometimes it is useful to repeat the tuberculin skin tests in children when their nutritional status has improved or their severe illness, including TB, has resolved, as they may be initially TST negative but positive after 2 to 3 months on treatment. A negative tuberculin skin test never rules out a diagnosis of TB in a child. The bacteriological confirmation, whenever possible, it is also advisable to confirm the diagnosis of TB in a child using whatever specimens and laboratory facilities are available. Appropriate specimen from the suspected sites of involvement should be obtained for microscopy and culture, and also histopathological examination. Appropriate clinical samples include sputum, gastric aspirates, and certain other materials such as lymph node biopsy or any other material that is biopsied. Fine needle aspiration of lymph node glands for both staining of acid-fast bacilli and histology has been shown to be a useful investigation with a high bacteriological yield. In addition to increasing the yield of confirmed TB cases, culture is the only way to differentiate Mycobacterium tuberculosis from other non-tuberculosis mycobacteria. Bacteriological confirmation is especially important for children who have suspected drug-resistant TB, HIV infection, complicated or severe cases of disease. The common ways of obtaining samples for smear microscopy include the following: expectoration. A is expectoration. B, gastric aspiration. C, sputum induction. A, expectoration. Sputum should always be obtained in adults and older children, 10 years of age or older, who are pulmonary TB suspects. Among younger children, especially children under 5 years of age, sputum is difficult to obtain and most children are sputum smear negative. However, in children who are able to produce a specimen, it's worth sending it for smear microscopy and mycobacterial culture. Bacterial yields are higher in older children, that's to say more than 5 years of age, and adolescents, and in children of all ages with severe disease. As with adult TB suspects, 3 sputum specimens should be obtained, and on the spot specimen at first evaluation, an early morning specimen, and a second on the spot specimen at follow-up visit. B. Gastric aspiration. Early morning gastric aspiration using a nasogastric feeding tube can be performed in young children who are unable or unwilling to expectorate sputum. Gastric aspirates should be sent for smear microscopy and mycobacterial culture. A gastric aspirate should be obtained on each of 3 consecutive mornings. C. Sputum induction. Several recent studies have found that sputum induction is safe and effective in children of all ages, and the bacterial yields are as good as or better than the gastric aspirates. However, training and specialized equipment are required to perform this procedure properly. Precautions are also necessary, particularly in patients with history of bronchospasm or bleeding tendency. Now, investigations relevant for suspected pulmonary TB and suspected extrapulmonary TB. Chest radiograph is helpful in the diagnosis of TB in children. The commonest picture is that of persistent opacification in the lung together with enlarged hilar or subcarinal lymph nodes or lymph glands. A similar pattern of opacification in HIV uninfected children is highly suggestive of TB. Patients with persistent opacification, which does not improve after a course of antibiotic, should be investigated for TB. Other tests include serological and nucleic acid amplification, such as polymerase chain reaction, the PCR, are not currently recommended for routine diagnosis of childhood TB, as they have been inadequately studied in children and have performed poorly in few studies which have been done. However, this is an area that requires further research as such this may be or may prove to be useful in the future. The common forms of extrapulmonary TB in children and corresponding investigations.